First off, I'd like to thank Dr. McKay for agreeing to do the talk tonight. We're quite looking forward to it. It should be a great talk. Damian McKay is a paediatrician specialising in paediatric and adolescent sport and exercise medicine and also rheumatology. He has a background originally as a physiotherapist and has a long-standing passion for the management of inflammatory and non-inflammatory conditions affecting the musculoskeletal system. Damian holds appointments with the Sydney Children's Hospital Network as a staff specialist in paediatric sports and exercise medicine and as a paediatric rheumatologist at Liverpool Hospital. He also consults from private rooms located at Miranda and also Moore Park. Damian has acted as an advisor for numerous key sporting bodies, including the International Olympic Committee, and is the current head doctor for the Sydney Swans Academy and a club doctor for the Cronulla Sharks Football Club. Damian brings his experience for the management and rehabilitation of elite athletes to all young, active kids and children battling with arthritis. So with further ado, Dr. McKay, thank you very much.
Thanks very much, Philip, and thank you, Lydia, also, and thank you to everyone for inviting me to chat. I sort of feel as though we've got a fair bit to cover, but I thought I'd focus initially just on going through the learning objectives for today. So what I really thought was worthwhile getting out of this session is hopefully just understanding some of the presenting symptoms and signs of common rheumatic disease in the paediatric population, discussing appropriate investigation and referral for paediatric rheumatic disease, discussing treatment options and side effects and also complications, and then understanding on a different tack some patterns of sports injuries in young and their management, investigation and the need for referral. And I guess as I sort of chat through some of the time, I'll be sort of I guess trying to highlight sort of that difference between, you know, a paediatric sports medicine presentation or sort of growing pains versus inflammatory conditions, and what are some of those sort of key red flags that are sort of, I guess, highlight the need for referral. So probably if I start with arthritis as the best place to start, is probably the most common rheumatic condition that I see, and certainly the most common rheumatic condition in children. It's interesting that the incidence, the prevalence, I should say, is 1 in 1,000 children, which is very similar to that of diabetes. Now, not all of those children go on to have long-standing arthritis, but it's certainly not an insignificant problem, and it's a problem that most practitioners will see throughout their life. Specifically with regard to juvenile idiopathic arthritis, it's an arthritis where the etiology is unknown. We do know a little bit more than that. We know that there's an autoimmune background to it, but this is the sort of current working definition. It begins before the age of 16, and it persists for greater than 6 weeks, and known conditions are excluded. Why 6 weeks? Well, predominantly because it allows for reactive arthritis or arthritis from previous infection with common sort of pathogens such as enteric pathogens, viruses, group A, strep, and even immunizations to resolve, essentially. So you're looking at resolution in the vast majority of cases by that 6-week period. And I guess if there's a clear history of antecedent infection, it wouldn't be unreasonable to manage in the first instance with, you know, a non-steroidal anti-inflammatory and close review. Looking then at those that then go past that sort of initial sort of period with prolonged symptoms, there are 7 subtypes of juvenile arthritis, so it's not sort of one, you know, homogeneous condition. It's actually quite broad, and we classify as either oligoarticular or polyarticular, so predominantly obviously on the basis of number of joints. Oligoarticular means 1 to 4 joints, and polyarticular 5 or more. And the polyarticular group is divided into those that are rheumatoid factor positive and rheumatoid factor negative. There's also systemic onset juvenile arthritis, which is very specific to children and quite rare in adults. And then enthesitis-related arthritis, which is akin to, I guess, a juvenile version of ankylosing spondylitis with some key differences. Psoriatic arthritis you'll be familiar with from adults, and then there's an undifferentiated group. If we look at this table, this is a table that I won't go over in full just at the moment, but I'll keep referring back to this, and sort of if you needed to take, I guess, one key slide or one key piece of information sort of out of tonight's talk, this is certainly sort of a very useful one to tag, because it looks through sort of the presentation of different forms of arthritis, and it not only helps with diagnosis, but as you can see down the bottom, it also may help you in deciding which serological markers to look at. So I'm going to start with the most common form of juvenile arthritis, and that's oligoarticular juvenile arthritis. And this is the most sort of, pronounced that a presentation may potentially sort of get. So you can see this is a child with juvenile idiopathic arthritis affecting their right knee. And you can see that it's a relatively subtle change, just some fullness sort of in the knee itself when you compare to the other side. And you can imagine sort of that in a child slightly younger than this, say 2 or 3 year old with podgy little knees, it might be difficult to actually determine if they've got an effusion or not. This is a younger child, and again, it's subtle, but you can certainly see sort of this fullness when you sort of look at the borders of the patella. So a typical presentation of oligoarticular arthritis would be a 3-year-old presenting just with a single swollen knee who's otherwise entirely well. And often there's this history of the parents noticing sort of the swelling following a minor fall from a swing. And really that's just serendipity. Often it's, the first time they've looked closely at their knee for sort of, for some time. In this particular case, it was persisting for a few months and the child developed a limp, but not necessarily describing significant pain, which is key. Now, I don't know why that slide is there. They're in the wrong place. Apologies for that. So if we look then sort of at this oligoarticular subgroup, it represents about half of all arthritis, much more common in girls than boys, and can happen at any age, sort of between about 2 and 12 typically, but very much a peak age of around sort of 2 to 3 years of age. Joint pattern is very important when we look at arthritis and helps differentiate sort of each of the subtypes. And so it's an asymmetric oligo or monoarthritis affecting large joints, most typically the knee, but can also affect the ankle, the wrist, or the elbow. The key extra-articular feature of this particular subtype of arthritis is uveitis, which is present in 20% and is much more common in those who are ANA positive. Now, in terms of ANA, we don't actually use ANA to make a diagnosis. You can certainly have oligoarticular JIA without a positive ANA. It really helps us stratify the risk for the presence of uveitis, and I'll talk about that a little bit later when we talk about management. Possibly less likely to be seen necessarily in practice, but certainly sort of in ED presentations is systemic onset juvenile arthritis. So this is a polyarthritis. Typical presentation you can see with sausage digits, fullness of the proximal interphalangeal joints, and a symmetrical arthritis rather than sort of asymmetry. The key feature of systemic onset juvenile arthritis is the presence of systemic features, so fever, rash in particular. This is a classic what's called Still's rash. Systemic onset arthritis was formerly known as Still's disease. And you get this very classic salmon pink rash that comes and goes with the fever. So it's not there all the time. The fever comes, the rash comes with it, the fever goes away, and the rash goes away. The fever is typically a quotidian pattern, which means that it occurs usually daily, sort of, and usually in the evening or at night. And so sometimes children will only sort of describe night sweats rather than fever. It's another good example of sort of typical salmon pink rash on an upper arm there. And the other interesting thing about the rash as well is it displays Koebner's phenomenon. So in any areas where there's direct pressure or scratching, you'll sort of get areas of the rash. In terms of investigations, these children often have an incredibly high white cell count. As you can see here, sort of, this is a patient who had a white cell count sort of up to 50, and sort of down here, this is sort of post-treatment. So the typical picture is a high white cell count, thrombocytosis as well, so platelets often up to 1,000, and this is post sort of treatment, but you can sort of see here that sort of hemoglobin was sort of in the 70s, and so you get this anemia of chronic systemic inflammatory disease. And typically very high ASR in the hundreds and a high CRP. And you can sort of see from that serological picture that often these children present looking quite unwell, and they potentially look septic, or they look as though they might be presenting with leukemia. So just coming back to our table then, representing about 10 to 20%, equal prevalence in boys and girls. The onset can happen at any age. The joint pattern is a symmetric, multiple small and large joint arthritis, and we have these sort of extra-articular features, including serositis, and the serological changes I've already described. The next form of arthritis I wanted to highlight is enthesitis-related arthritis, and I think this is an important one, in part because it's one that people haven't necessarily heard about, and in part because it's very easy to see an overlap in active young kids, and I'll explain why. If we start with a case presentation to give you a feel for how somebody might present, a 12-year-old boy presents with right heel pain, and he's had difficulty playing sport for about 2 months. It was first noted when he was playing touch football, and there was really no history of specific injury. The pain seemed to be worse when he was walking or running, but as a key feature, he sometimes felt stiff in the morning in his heels. And at that stage, there was no pain or swelling in any other joints. He had a pretty unremarkable past medical history. He'd had a rapid period of growth. He was a relatively active young man who played AFL and touch football. And so certainly had enough, I guess, training or playing load to explain his symptoms from a mechanical perspective. And certainly when he was examined, he had some poor lower limb biomechanics that might have contributed to mechanical pain. And when his right ankle was examined, he really just had tenderness of the tendo-Achilles insertion and the calcaneal apophysis. And he was initially managed as Sever's disease, which I think is entirely reasonable given his initial presentation. So Sever's disease we'll talk about a little bit in the future. Many of you will be familiar with it. That's one of the more common forms of growth-related pain in active kids. This boy was managed with ice and a heel raise and relative rest. But despite all of that, he didn't get better. In fact, with rest, he was getting worse. He was getting stiffer in the morning. And when he was re-examined, he had a small ankle joint effusion. And at that stage, investigations were undertaken. His blood count was normal. His inflammatory markers were normal. And I guess that's a key learning point sort of in children that present with arthritis when they just have a monoarthritis or a few joints or just isolated enthesitis, as this boy did. And you'll often have normal inflammatory markers. So you certainly can't exclude an inflammatory arthritis in somebody who has normal inflammatory markers. An ANA was done, it was negative. A rheumatoid factor was also done. The key one done here, given his presentation, was the Hla V27, and that's positive. He also had an MRI, and what we see on the MRI is a few features. We can see a small effusion in the posterior recess of the ankle. We can also see some patchy osteitis in the talus, and then around the calcaneus we can again see some osteitis there and some increased signal at the tendo-Achilles insertion. And on this film here, what we can also see is just a little sliver of fluid around the tendon, and that's representing tenosynovitis. He ended up progressing to have also a small effusion in his right knee, and he was referred and diagnosed with enthesitis-related arthritis. So coming to that particular subgroup, it represents about 15% of all arthritis. It's much more common in boys and girls. It's the only form of arthritis that is more common in boys and girls. It very typically presents in adolescence. It rarely presents below the age of about 8. The joint pattern is asymmetric, large joint. There can be axial skeletal involvement and sacroiliitis, and in particular that's true in those who are Hla V27 positive. And I guess this is the interesting thing about this. Although this is a relevant marker in enthesitis-related arthritis, this is only present in 80% of kids with that subtype of arthritis. So 20% have normal serology, and so it does make it sometimes difficult to differentiate between mechanical problems. They do get uveitis in terms of extra-articular features, but the difference is it's symptomatic uveitis with a red, painful eye as opposed to the quiescent uveitis that you see in oligoarticular arthritis. Enthesitis we've discussed, and also an association with inflammatory bowel disease. So just to remind you, and also to highlight sort of the difficulties in making the diagnosis, the enthesis is the insertion of the tendon onto the bone. It's actually a separate structure, Sharpie's fibers, and a few other sort of structures. I describe it sometimes to patients as the nail that nails the tendon into the bone, or the nail plate that nails the tendon into the bone. You can see that from a surface anatomy point of view, it very closely overlies, in this case, the tibial tubercle apophysis. And so from clinical examination point of view, if we're pressing in on here, it's quite difficult to determine somebody who has enthesitis versus somebody who has apophysitis. Just a little bit of histopathology. This is the enthesis on ultrasound, and then in cadaveric section, you can see the enthesis sitting in the middle here of the calcaneus, this being the bone, and then sort of the tendon just there. So just to highlight the difference is both in terms of structure, but also in terms of etiology. So enthesitis is inflammation of the insertion of a tendon or ligament into bone, and it's an autoimmune etiology. Whereas apophysitis is repetitive traction of the apophysis, or the growth plate at the insertion of bones, and it's a mechanical etiology. So it is a difficult diagnosis to make, and you need either the presence of both arthritis and enthesitis, or if you only have one of those two features, you need two other features. And in this particular case, this boy didn't have sacroiliac joint tenderness, but he did have a positive Hla V27, and his symptoms did begin after the age of 6, and of course he eventually went on to have arthritis as well. As I said, it's much more frequent in boys than girls. The common sites of enthesitis tend to be in the lower limbs, the inferior pole of the patella, the tibial tubercle, the tendo-Achilles and the plantar fascia insertions, and the other places also on the lateral hip, at the greater trochanter at the insertion of the gluteal muscles. The arthritis typically affects the lower limbs, so hips, knees and ankles. More typically is asymmetric, but can be symmetric. It rarely progresses to spinal symptoms in the sense of true ankylosis. So although you can get some sacroiliitis, it doesn't sort of progress to a full-blown sort of ankylosing spondylitis as you might expect in adult patients. In some ways related, certainly in terms of pattern and also in terms of serological markers, is psoriatic arthritis. And I'll just go to my picture here. So psoriatic arthritis, this is typically what you see. So there's a few features here that might help us differentiate a little bit between other forms of arthritis. So involvement of the distal interphalangeal joint is quite typical for psoriatic arthritis. The other sort of feature there is the asymmetry. So you sort of often have very random joints picked out with psoriatic arthritis. So it might be a DIP here, it might be an MCP here. Sort of it's really quite sporadic in terms of which joints are affected. You can see an IP joint here in the right thumb. Another IP joint sort of here, psoriatic nail, sort of on this side. And again, you can see the asymmetry. And the key feature here is dactylitis. So you can see the clear difference from the left to the right. And so dactylitis really is a combination of tenosynovitis, enthesitis, plus arthritis. And in this case, the arthritis looks to be both in the proximal and the distal interphalangeal joints. This is an example of the symptomatic uveitis. I don't think that's showing very well on the screen. I apologise, but you get this sort of typical sort of red eye that's painful. And a few more examples of bilateral dactylitis. Again, it doesn't project very well, but a psoriatic nail there. I threw this one in just because it's something that often trips us up a little bit. This is a patient who presented with swollen digits. They were starting to get better by the time I'd seen them. This is actually a girl from the Blue Mountains who in winter was wearing these shoes, and she's got chilblains, and it's often difficult to tell when the chilblains are extensive. And probably the key feature from a history point of view is asking for the presence of itching. So with dactylitis, you won't get itching, even as it's resolving, but chilblains quite classically, and in particular when there's sort of a little bit of skin ulceration, will be quite itchy in the resolution phase. And again, another example of chilblains in that child. Okay. Talking a little bit then about diagnosis and referral. I think the key thing really to say about juvenile arthritis is it's a clinical diagnosis. There's really no one test that's going to help us easily make the diagnosis. It's a combination of history and clinical findings, and occasionally the serology helps a little bit. I sort of often describe it to patients as it's like trying to put together a jigsaw puzzle, and you just need enough pieces of the 30-piece jigsaw puzzle. You just need 3 or 4 to be able to sort of make out the picture as an elephant or a dog or whatever. There are some key features, however, that really do help. I guess some key things that red flags that help us in terms of thinking about the need for referral, and are really big pieces of the jigsaw puzzle. And one of those key features, and one of the key discriminating symptoms between mechanical joint pain and inflammatory joint pain is the presence of significant morning stiffness. So not stiffness that lasts, 2 or 3 minutes, and certainly not the stiffness that you might see in adults or described in adults, or pain you see described in adults with tendinopathy, who are often quite sore when they first jump up in the morning. But it's stiffness that's lasting, at least half an hour, but frequently, 2 hours. I saw a boy today, sort of, whose stiffness improves about 6 hours into the day. The second thing is the presence of a persistent effusion. I think the key message there is an effusion in a child that persists is not normal, is not from a mechanical cause, and is juvenile arthritis until proven otherwise. And obviously the involvement of more than one joint increases the possibility that it might be an arthritis as opposed to a more mechanical cause or growing pain. Just in terms of diagnosis, I've spoken a little bit about serological markers, and I wanted to talk a little bit about the rheumatology screen. It's in inverted commas there because rheumatologists don't know what a rheumatology screen is, because we don't really screen on the basis of doing all tests. Essentially, we assess the presentation and then match which markers we might pick depending on what we think is the most likely sort of condition. Now, the caveat to that, of course, might be a 6-year-old child where you're thinking, okay, I think it's, ANA positive oligoarticular arthritis, but I guess maybe it could be, it could be psoriatic arthritis or Anthocytus related arthritis, and I don't really want to stab them twice, so therefore I'm going to do a couple. ANA is associated with both oligoarticular arthritis, but also polyarticular arthritis, and obviously also with other autoimmune conditions such as lupus. Rheumatoid factor is relevant in particular in polyarticular juvenile arthritis. Anti-CCP antibodies are also relevant in that group, and often will become positive prior to rheumatoid factor changing. So you'll often see that sort of changing, at the time of presentation of symptoms, with rheumatoid factor potentially changing 3 months down the track. Hla V27 we've discussed in terms of its association with Anthocytus related arthritis and also psoriatic arthritis. These are the ones that often sort of creep into the rheumatological sort of screen, and probably I'd be saying sort of, do we need to do that? And in a child that's presenting at 3 with a monoarthritis of their knee, it's reasonable to say, oh, maybe they've got oligoarticular, maybe it's an atypical presentation of rheumatoid arthritis with a monoarthritis. Certainly it can fit into this, but what they certainly don't have is lupus. They don't have juvenile dermatomyositis. They don't have, an ANCA-associated vasculitis, and so I'd be sort of limiting investigations to this. The only other thing to say, just in terms of serological markers, is just highlighting sort of ANA and also Hla V27 being relevant only when you have the presence of symptoms that suggest inflammatory disease. So if I have somebody who has mechanical joint pain without the presence of arthritis and their ANA is positive, then they're likely to just be one of the 10% of the population who normally have a positive ANA, and will always have a positive ANA even if we test it again in 20 years' time. And similarly, somewhere between 5 and 15% of the population, depending on ethnic background, are Hla V27. And so we sometimes can easily get tripped up by interpreting those markers as being relevant in somebody who very clearly has mechanical musculoskeletal disease rather than inflammatory musculoskeletal disease. Often the main benefit in investigations is to exclude other causes, and certainly the one key investigation that children who are presenting with arthritis should always have is a full blood count, because up to 30% of kids with ALL can present with arthritis or arthralgia as their initial symptom. And I can think, usually sort of there's probably one child every 3 months at the Children's Hospital at Westmead who presents with, significant joint pain and doesn't have arthritis, but in fact has leukemia. And I guess that's the other thing to sort of comment too, is that in terms of the differentiation between those two things and also mechanical joint pain, it's interesting that children with arthritis, while they do get pain, they don't always have extremely significant pain that's incredibly disabling. I see many more children who present with idiopathic musculoskeletal pain or chronic pain who can't go to school, as opposed to the kids with arthritis who somehow manage to battle on despite their marked effusion in their knee. I guess the gold standard from a diagnostic perspective is synovial fluid analysis, and sometimes we might use this to confirm a diagnosis when we're unsure. The key feature really is the presence of inflammatory range cells in an aspirate that has no growth of any organisms. Talking a little bit about management, and we've certainly come a very long way from a management perspective in arthritis. Your eyes don't deceive you. This is a bottle of arsenic, and that was one of the very first treatments for arthritis. And in comparison, on the right, we have one of the most recent treatments, which is tocilizumab, which is an IL-6 inhibitor. And so through the ages, we've moved from arsenic and cod's liver oil to salicylates, gold salts, which have gone out of use to a large extent, certainly steroid hormones, and then prednisone, and really methotrexate was the key change in the 1980s, the introduction of methotrexate. What I should have also included here in the 1990s is intra-articular corticosteroid joint injections, and that's really one of the key ways in which we manage arthritis. And obviously more recently we have targeted cytokine therapies. So if we look at how we manage now, non-steroidal anti-inflammatories provide symptomatic relief, but they don't actually act as a disease-modifying agent, even in children who get full resolution of symptoms. Some very nice studies looking at long-term outcomes of arthritis in asymptomatic kids, and essentially, despite being on non-steroidal anti-inflammatories, despite reporting no symptoms, despite having a normal clinical examination, they went on to develop joint degeneration and also growth discrepancies. Because of that, corticosteroid injections are the hallmark of treatment, certainly of oligoarticular arthritis, but also used as an adjunct in polyarticular arthritis to treat individual joints. For those where there's too many joints to inject, and often injecting that many joints isn't as effective as injecting just one or two joints, methotrexate's been fantastic in the management of kids. It's great because it's a once-a-week medication, so from a pragmatic perspective, it's really easy to use. Oral corticosteroids, although they have their place, really only have a place ideally these days as a temporizing measure to basically allow us to control disease whilst we're waiting for either methotrexate or whilst we're waiting to move patients to newer medications, of which there's a number, TNF-alpha inhibitors, interleukin-6 inhibitors, which we tend to use specifically for systemic onset juvenile arthritis because it's fantastic at dampening down that cytokine storm that causes the fever, rash, etc. And then JAK kinase inhibitors, which is used in adults for rheumatoid arthritis, is also being used in our kids, both who are seropositive, so those who are rheumatoid factor positive, but it's also very successful in the ANA positive polyarticular arthritis group. Talking a little bit about disease complications now. These are photos from George Frederick Still's initial dissertation on a form of arthritis in children. It's actually a really interesting article to read, and something that he wrote as a registrar, which was very impressive, I must say. And you can see, before we had treatments, we can see the fusiform swelling sort of in these sort of children, sort of in the ankles, in the elbows. You sort of often get this really marked hepatosplenomegaly with protruding abdomen, and wasting of muscular from just profound systemic inflammatory disease. This is a more recent photo. Apologies, my screen over the patient's name hasn't worked there. This is a patient who had systemic onset juvenile arthritis, and you can see here we have quite marked degenerative change within the carpal joints. And the other thing that you can see, if you sort of just train your eyes backwards a little bit, is one of the key features of ongoing inflammation around joints, and that's, we can see here, if you look at the degree of osteopenia in the metacarpals, the phalanges and the carpal joints compared to here in the forearm, and even sort of if you look at the distal radius and compare here to here, you can sort of see that periarticular osteoporosis that's typical of prolonged inflammatory disease. Again, we can see really profound sort of changes. These look like the knees of an 80-year-old, and sadly the knees of a 16-year-old with almost ankylosis bilaterally of the knees. Similar profound changes here in the hip joints of this child. And thankfully, we don't see that as often. As well as the joint changes, in particular in systemic inflammatory disease, we get growth retardation. It's difficult, sort of steroids obviously cause growth retardation, and we try to avoid them from that, but systemic inflammatory disease does as well. So this young man is this boy's twin, and this is the younger brother. And so you can see how sort of profound sort of that growth discrepancy was. What was amazing was when he was started on an IL-6 inhibitor when it first came out. This is a photo that is probably about 8 to 10 years old sort of now. He actually had quite profound catch-up growth where he had at least caught up to his younger brother, didn't quite catch up to his older brother, but it was amazing the change that we saw. Obviously see the Cushing-oid face there as well from long-term steroid use. So in terms of complications, the key things are articular cartilage damage, bony erosions, and in children, if they're still growing, we can get a leg length discrepancy as one of the key difficulties if we don't control disease effectively. These problems can potentially be affected by delays to diagnosis. So I've certainly seen some children with less than 6 months of symptoms with aggressive disease, and in particular those who are rheumatoid factor positive, who tend to have more aggressive disease. They can present with erosions at the time of presentation. And so just highlighting there that the subtype really does have that sort of influence on disease complications. And certainly what we do know is that if the kids are managed early by a paediatric rheumatologist, and ideally a multidisciplinary team, then outcomes have been demonstrated to be better. It's interesting if you compare delays in diagnosis across different countries. Australia unfortunately doesn't fare very well. I think that's probably a combination of a paucity of paediatric rheumatologists together with just not the opportunity for us to get the word out easily. But certainly you can sort of see in other countries who have invested heavily in paediatric rheumatology services, there's still a potentially significant delay of anywhere between 3 and 7 months from the time of onset of symptoms to the time of actual diagnosis. A little bit on prognostic factors in terms of oligoarticular juvenile arthritis. There are certain kids where we know that they're not going to do as well. Certainly if you have hip involvement or cervical spine involvement, you're less likely to have well-controlled disease, or if you do go into clinical remission, you need to stay on medication to remain in clinical remission. Arthritis of the ankle or the wrist in particular tend to be problem joints that don't always respond to intra-articular corticosteroid injections, and sometimes need methotrexate or sometimes even biologic agents to control disease. And then obviously if you present with radiographic damage or develop radiographic damage, then you tend to have a poorer long-term prognosis. In terms of polyarticular juvenile arthritis, as I said, the presence of rheumatoid factor or anti-CCP antibodies increases your risk, as does either hip or cervical spine involvement, and again, if there's radiographic change. For systemic arthritis, arthritis of the hip, or in particular, is a really poor prognostic factor, and some children in the past, thankfully not as frequently, have needed to go on to total hip replacements as an adult. In terms of systemic features, if children have 6 months duration of significant active systemic features with fever and elevated inflammatory markers and an ongoing requirement for systemic glucocorticoids, then they're much more likely to have ongoing systemic features and require ongoing medication to keep them in clinical remission. In terms of complications, this is really one of the key ones that we need to address, and also in terms of delays to diagnosis, because certainly some kids do have uveitis present at diagnosis. This is an example of a child with quite profound disease already. There's a cataract present. You see this irregular margin on the iris and the presence of posterior synechii, which is basically scarring from prolonged inflammation, causing sort of discrepancies in this child's vision. And that's really the issue with uveitis. By the time, you know, a child has deterioration in their vision, that deterioration is not fully reversible, even with medication. Because of that, we like to immediately rule out the presence of uveitis at the time of diagnosis, and then depending on whether children have oligoarthritis or polyarthritis, and depending on whether they're positive or negative for their ANA, then they need screening every 3 months for 4 years, and then sometimes for up to 7 years. A little bit of discussion on medication complications, just because it's obviously something that might be alerted to the family physician, general practitioner first. Non-steroidals can cause gastritis, but interestingly, far less frequently than they do in adults. I've certainly got kids who have been on naproxen for 1, 2, 3 years, and they tolerate that quite well. Corticosteroid injections, from a complication point of view, there's very little complication other than the expected childhood fear or anxiety of having a procedure. Methotrexate, although reasonably well tolerated in a lot of children, certainly in higher doses, can cause fatigue, nausea. Adolescents talk about sort of brain fog and mood change. And one of the key things is liver function derangement, and that's why we would routinely start methotrexate, check liver function tests after 1 month, and then every 3 months routinely. And then certainly after a change in a dose, we'd sort of go back to watching sort of about a month after a dose change, just to make sure that we don't have liver function test derangement. There are some strategies we can use if some of those complications of methotrexate arise. Changing folic acid timing and frequency is one thing that certainly helps with fatigue and nausea. The other thing that's useful is sometimes splitting the dose. So rather than taking 20 milligrams once weekly, you can take 10 milligrams on Saturday night and 10 milligrams on Sunday morning, and that seems to help both with fatigue and nausea, and also issues with liver function. We're all familiar, obviously, with the complications of corticosteroid use, in particular the long-term complications. And then I thought I'd just mention briefly the complications of biologics. Obviously, sort of initial concern about their immune system effects, but in reality, the risk of infection is relatively low. Having said that, we have had in the last 10 years 1 death in New South Wales in a child on a biologic, so certainly you know, the risk is there, but it's interesting when we have information from our US colleagues who unfortunately are seeing a lot of kids with rheumatic disease who also happen to be getting COVID. Being on a biologic isn't a risk for more severe COVID, however, being on oral corticosteroids is. Probably the main issue that kids don't like with biologics is just the pain from the subcutaneous injection. We can certainly use ice and other sort of strategies to help with that, but one of the main issues is that Humira, the most common biologic used in juvenile arthritis, has citrate as a preservative in it, and it causes a localized reaction. It's basically, obviously, like injecting a bit of lemon juice into you, but thankfully, I think as of maybe April next year, there will be a citrate-free version available in Australia. Just finishing up on complications, this is that little boy, little girl with systemic onset arthritis, and you can see here a vertebral crust fracture from her osteoporosis from long-term steroid use. I thought I'd briefly, I don't have time to go through all the rheumatic diseases that we might see, but I just thought I'd remind you that rheumatology, of course, is not just arthritis. Just go through a few interesting shots. This is a little girl with juvenile dermatomyositis, which is an inflammatory myositis, the most common inflammatory myositis in children. She presented with her mum thinking that she had eczema, which she wasn't overly concerned about, but when she had difficulty climbing up the play equipment, she was referred by her general practitioner. So this is sort of a typical sort of this erythematous skin rash that you see with juvenile dermatomyositis. One of the key features is Gottram's nodules, which typically happen on the extensor surfaces of the MCPs and the proximal interphalangeal joints. And again, you can just see this sort of generalized erythema of skin. They often have a malar rash, as you typically see in lupus. It does have a slightly different sort of appearance, just seems to be erythematous and sometimes described as violaceous in that it's sort of slightly purple rather than sort of red. The rash typically affects not only sort of the malar region, but also typically this what we've described as a heliotrope rash on the eyelids as well. And so really it's important to get the kids to close their eyes so that we can look at that. And there he is closing his eyes for us. One of the other features of juvenile dermatomyositis, which is essentially a vasculitis of the skin and muscles, is the presence of nail bed changes. We can see in close-up here, what you get is a little window into what's happening in the muscles. So we can see here sort of multiple areas of vasculitis with these enlarged blood vessels. Again, we can sort of see it quite nicely. Sort of you see little loops of the vessels. Now, you don't need any fancy equipment to look at somebody to do their nail fold capillaroscopy. All you need is an otoscope, and you drop a little bit of water just on the margin here and look through with your otoscope, and you can beautifully see any changes that may be present. Another image here, I'm just showing us the same. The diagnosis previously was made via muscle biopsy, but now MRI has allowed us to look for very typical changes of increased T2 signal reflective of myositis. Excuse me. In terms of complications, one of the skin complications is the presence of calcinosis, and we can see calcinosis on extensor surfaces of the elbows here, probably made worse by the pressure effect on the elbows. That's why it's one of the more common areas. And you get this extrusion of calcium deposits, and once the skin breaks down, it really looks like toothpaste, essentially sort of coming out from the skin. And it's just present because of chronic skin inflammation. You can sort of see here again, sort of on the knees, aspects there. Mentioning briefly lupus, I just put the classification criteria up there, not to commit to memory, but just to remind us that lupus can present in a multitude of ways, and not just the typical sort of malar rash with constitutional symptoms that we might see. This particular girl presented with neuropsychiatric lupus, and so that's why she has a very flat affect. You can see the malar rash there. This young girl also has a typical malar rash. And if I move to this slide here, one of the other key features that's often present at a presentation in lupus is the presence of ulcers, but very specifically hard palate ulcers as opposed to ulcers on the gums. And then the vasculitic rash of lupus can be very, very subtle. It can just be little sort of skin changes, sort of like this, as opposed to a widespread vasculitic rash. And probably the only other one to sort of mention autoinflammatory disorders, and this is essentially the periodic fever syndromes that we see. And I guess the difficulty is always differentiating those from recurrent viral infection. The most common one, which I'll just highlight rather than all, is familial Mediterranean fever, which is much more common in Turkish and Arabic families. Very typical duration of attack of between half a day up to 3 days, and a frequency usually of about once a month. And then some parents will describe that it's almost like clockwork. They don't have a preceding virality, obviously, and they can get abdominal pain from peritonitis, they can get pleuritis, they can get monoarthritis or just arthralgia, they can get an erysipelas-like rash on their lower legs, and then there's a range of rarer symptoms that are present. So just a reminder that sort of recurrent fevers is something that we also deal with. And with that, I might stop for a brief glass of water. I don't know, Philip, if you wanted to stop at this stage to invite questions before we move on to sports medicine.
We've only got one question, which will probably relate a little bit more to your sports medicine, so we can probably ask that a little bit later on. But the only other thing was, with children on the biologics, we still have to be very careful with the vaccinations and everything.
Yeah, good point, actually. We should have mentioned. So live vaccinations are the key issue. So the ideal situation before, in fact, methotrexate also potentially is an issue. So ideally, before we start methotrexate, we check kids' vaccination status, and in particular, varicella is the one that always crops up. Usually when I'm starting somebody on methotrexate, I'll check their liver function tests, I'll check their varicella serology, and if they haven't seroconverted, then I would give them a booster. And I'd also do a quantiferon gold, make sure they don't have tuberculosis, because that'd be a disaster on a biological methotrexate. Now, it's pretty rare, but it has happened before where somebody's been found to be exposed to tuberculosis.
Thank you. Another question has just come in. How is osteoporosis treated in children?
Good question. It's treated with bisphosphonate therapy, so usually by the endocrinologists out at Children's Hospital of Westmead, the specialists that are involved. So usually it's, you know, from an assessment sort of point of view, it's a combination of features. Firstly, confirming the presence of osteoporosis with bone mineral density that's less than 2 standard deviations below normal, but we also use another investigation called a PQCT, a peripheral quantitative CT scan. Essentially what that shows us is bone morphology. Really nice images, essentially looking at cortical thickness, trabecular thickness, cortical bone density, trabecular bone density. So I often describe it to patients as bone mineral densities sort of tells us how many bricks is in the building or how much calcium is in the body, whereas a PQCT is like the building plan. It tells us if it's single brick or double brick, single brick or double brick. So, and if those are abnormal, then they might move on to bisphosphonate therapy, and typically that's given as IV infusion, and then obviously monitoring thereafter.
Thank you. No, I think that seems to be. Sorry, another one. Does vitamin D have any role for osteopenia in children?
It does, predominantly just because it's, you know, the building blocks of strong bones. So, you know, working anybody up for either secondary osteoporosis or vitamin D deficient rickets, or, you know, sometimes I do this in terms of the kids that I see in sports medicine where they're presenting with recurrent stress fractures or a history of a lot of long bone fractures. And we now know that there's certainly a lot, I've forgotten what it's up to, about 9 different subtypes of osteogenesis imperfecta now, and some of them are very subtle. So essentially you use vitamin D and calcium to make sure you've got those basic building blocks of bone, and that's part of the investigation, sort of, you know, when you're first looking at potential sort of causes, making sure that calcium is normal, vitamin D is normal, parathyroid hormone, the hormone that controls sort of those two things, is also within normal range.
Okay. All righty. Well, that seems most of the questions so far. So I think if you've been a little bit refreshed, we can move on to the sports medicine part. That'd be much appreciated. Great talk so far. You're doing very well. Thank you very much.
Okay, thanks, Philip. We'll keep moving on then. My other passion in life being paediatric sports medicine. I'm just going to, I don't know, little formatting issue there. I don't know why that's done that. Okay, all right. So I'll give you just a fairly typical boy that I certainly might see, and I'm sure you all have as well. This is a 12-year-old boy who is recently been selected for the state squad in soccer, and he's presented with some bilateral heel pain. He's got a coach who thinks he's the next superstar and is wanting to push him even harder, and is presented with his 3rd injury or issue this year, and his father's asking why. And so really this highlights the 3 things in children, is that they have very unique patterns of paediatric sports injury when we compare them to adults. There's a risk of overtraining in all children, but certainly understanding what that risk is, and in particular what that risk is during a period of skeletal maturation, is very important. So the first thing is to go through those very unique patterns of sporting injury. And when we look at kids who are involved in sport, much as they're adults, they'll have risks according to the biomechanical nature of the sports that they're involved with. So the picture on the right is really loading up the medial structures of his elbow there and putting his capitellum at risk with that throwing action. And then the gymnast on the right is putting about 75% of the body weight through her distal radius. And again, sort of that's something that potentially predisposes her to injury. The other reason, of course, kids have a different pattern of injuries despite those normal activities that they might be involved in, is the presence of growth plates. And so we looked at this image before, but just to highlight the differences, we're familiar with the physis present at the top and bottom of all long bones, responsible for somatic growth in kids. But we often forget about the apophysis. Now, the apophysis is the growth plate that's present at the insertion of a tendon onto a bone. And most of us certainly are familiar with this one here at the tibial tubercle, being a common site of injury, but we have to remember too that there are literally hundreds of apophyses around the body, and depending on the particular sporting activity the child may be involved in, they can certainly have issues with that particular location. The other significant influence, of course, on paediatric sports injury is growth, and I think this picture always nicely highlights sort of the growth discrepancy that we see in girls between 10 and 12 years of age and boys between 12 and 14 years of age. And we can see that nicely when we look at this slide of timing of pubertal milestones. Girls, as you know, tend to mature sort of early, about 2 years earlier than boys do, reaching their peak height velocity at the age of 12. Boys starting to mature typically a little bit later and hitting their peak height velocity at the age of 14. But obviously, as the previous slide suggested, certainly a great degree of variation, as we can see in these blue bars sort of here. What we also see from a sporting perspective, these are models of youth physical development that they use in sort of youth academies, sporting academies, etc. What we see in sort of girls in that earlier sort of 10, 12, sort of 13, 14 sort of age group is massive increases in height with the timing of peak height velocity at the age of 12, and at the same time really massive improvements in physical qualities such as agility, speed, power and strength, muscle hypertrophy and endurance. See the same thing in boys, with the main issue being that it's just offset by 2 years. And so often these higher speeds, more power, more strength are also some of the contributors to injury as well. What I find really interesting though is to sort of think about what actually happens to the skeleton as kids grow, because it's not just all about somatic growth. There are actually tissue property changes that occur during maturation. And I guess what I mean by that is the biomechanical properties of the skeleton change and the mechanical properties as well. So we know for a start that articular cartilage is weaker in immature cartilage as compared to mature. That's certainly from only from animal studies predominantly, but we certainly see that in the pattern of injuries that we might see, which I'll describe later. We also know that when there's increased growth of the in kids, that the growth plate is thicker, and when it's thicker, it's more fragile and more easily overloaded. And that's present both at the physis, but also at the apophysis that we were looking at earlier, and obviously present throughout the body. What's interesting is there's this association between peak height velocity and also peak fracture rate, and essentially there's a drop or a relative drop in bone mineral density during that period of peak height velocity. And so although the bone mineral content is increasing, it's just that it can't keep up. And so I sort of describe it to the families as it's not that we're losing calcium, it's just that the amount of calcium in the bucket is relatively less because the bucket is getting so much bigger and happening so rapidly. The other thing that we see is peak lean tissue mass increases, but unfortunately it increases sort of just prior to the decreases in bone mineral density. So essentially you've got sort of stronger muscles and weaker bones and also weaker growth plates. And so you can sort of start to see why we get sort of some of the patterns of injury that we do. The other thing that's out sort of in terms of evidence a little bit is just the influence of flexibility on the adolescent growth spurt. Certainly there's not great evidence to say that kids become less flexible as they grow, but certainly some of us notice that in clinical practice. So I guess with that as a background, I just wanted to discuss some common sports injuries that we see in kids. And again, sort of, if you're looking for another sort of take-home message out of all my chit-chatting, this is, again, the slide to look at, because we had this group of conditions called the osteochondroses, and essentially they're the growth-related conditions. And I like to, I guess, separate them into extra-articular osteochondroses, intra-articular osteochondroses, and physeal osteochondroses. And that's useful sometimes from perspective of talking about sort of risk of complication as well. I'll talk about that in a while. So if we come to our quite familiar presentation that we saw before, a 12-year-old boy with activity-related bilateral heel pain with no history of injury and recently increasing his level of activity in the context of a recent growth spurt. We see a fairly typical pattern for Sever's disease. This particular boy had poor lower limb biomechanics, and as you can see, the same clinical examination findings that we had in a child that initially was thought to have Sever's disease, but of course went on to have Anthocytus-related arthritis. So Sever's disease is essentially an irritation of the calcaneal apophysis. It's an extra-articular osteochondrosis, and by that I mean it's away from the joint surface. I think that's really important to know when you're talking about reassuring parents, because I think one of most parents' fears is that, is this a condition that's going to cause long-term damage? Is it going to cause arthritis later in life? And the answer is no. Once that growth plate is closed, their symptoms will go away. Typically it happens between the age of 9 and 13, a little bit earlier than Osgood-Schlatters disease, and I think that's related to the way in which children grow. They grow from the feet first, so they have growth of their feet and hands in the early stages of puberty, and then arms and legs sort of kick in after that, and then when the feet stop growing, sort of, and the arms and legs stop growing, they still have some axial growth. And so I think what we're just seeing is symptoms related to, massive increase in foot size. More common in boys than girls, but certainly prevalent in both, and very typically is activity-related heel pain. It can be bilateral. It occurs because of traction of the muscle tendon unit on the apophysis, and it's probably influenced by flexibility, by changes in biomechanics, by rapid growth, all of which lead to excessive loading of the apophysis. In terms of how I like to manage Sever's disease, I talk about simple measures such as using ice to the heel after exercise. One of the key things is trying to unload the apophysis. So as we sit in dorsiflexion with our feet on the ground without wearing shoes, then we just put more tension on the tendo Achilles and therefore more tension on the calcaneal apophysis. So unloading with the heel raise is useful. Getting kids to wear good running shoes with a heel raise, the ASICS sort of style rather than say Vans or Converse, where there's really no heel rise. That's important. Football boot choice is really important to mention. Often we'll see an influx of Sever's disease at the early stage of the soccer season. It's going to be in part related to increases in physical activity. It's probably related to hard grounds at the beginning of summer, but it's certainly related to the fact that the majority of football boots only have a 3mm heel rise on them, whereas there's only, I think, 2 brands that have that higher sort of 10mm heel rise, and certainly just simply switching kids over from the boots that they love and all their friends wear and their idols wear to ones that are more appropriate biomechanically usually leads to success. Calf stretching can be important, but just caution them against overstretching the calf, because that's just really just pulling on the apophysis even more. And so that's why sometimes using a foam roller is a useful alternative. I've put insets in there. I don't typically, and certainly probably 5 years ago, I didn't typically sort of use non-steroidal anti-inflammatories to manage Sever's disease and other forms of traction apophysitis. I think the only caveat to that is to remember to look at the big picture. And I think the big picture is, for some kids, sport is a very important part of their identity and well-being, and also their mental health. And so, although you might be sort of putting somebody on a non-steroidal anti-inflammatory to get them to the rest of the season, or to get them to be playing sort of 1 game a week, you know, that might be enough to keep them sort of rolling in terms of their overall health and well-being. The key part of management is talking to families and mums and dads and reassuring them that it's a benign and self-limiting condition that will go away when the children stop growing, and that because of that, it's not unreasonable to talk about not necessarily stopping training, but modifying training to reduce impact loading and to manage their symptoms at an acceptable level where they can, you know, wake up the next day, be comfortable, get to school. So certainly modifying training is a useful strategy. Decreasing their overall load is another useful strategy. So sort of, you know, if they're playing, you know, 3 games of soccer and 2 games of OzTag, getting them to make a choice is important. And obviously, sort of for those who are really affected, you can sometimes substitute less impact loading activities. Very rarely I use a cam boot for a short period of time just to unload someone pretty rapidly. That's usually sort of when they have a particular tournament that they want to get to in 6 or 8 weeks' time. And then, as all things in sports medicine, we use a graded return to training, and that's in part so that we don't cause any damage and stir things up, although that's less of an issue in the sense of returning a kid with Sever's disease, but certainly it helps you from overshooting the mark and sort of going back to square one. Osgood-Schlatter's is probably the most common form of traction apophysitis. I'm sure you'll all be familiar with that. We were talking a little bit about complications just a moment ago. I think that the one caveat to talk about is Osgood-Schlatter's seems to be the one area where one of the long-term complications is the development of bony ossicles, which can then sometimes cause symptoms even once the growth plate's closed. And so you'll often come across athletes when they're sort of 17, 18 who need excision of that bony ossicle. Otherwise, it causes tendinopathic changes. Just whilst we're on the apophysis, the other thing to mention is acute injuries to the apophysis, and this is an example of a rugby league player who was sprinting, and as he took off to sprint, felt an acute onset of left hip pain. And we can see here a shadow that's asymmetrical compared to the other side. And on this scan, sort of here, we can see an avulsed apophysis. Clinically, they would present with pain with extension, because as soon as you extend, you're putting sort of that area on tension and pulling it away. They sometimes get a little bit of pain with flexion, but that's more just because of a pressure effect of the thigh as it presses up here. What they certainly get is pain with activation of the muscle. So if you tried to get this child to straight leg raise acutely, they probably couldn't. And certainly for at least a few weeks, they're quite weak and have pain sort of when they do a straight leg raise or with resisted flexion or resisted knee extension. And also they have tenderness on palpation there. So moving on to the next form of osteochondrosis, I wanted to talk briefly about the intra-articular osteochondrosis. Important to mention because the complication risk is certainly more significant. I'll present to you this young lady who was 11 and had about 3 months of elbow pain with no history of trauma. The pain was worse with activity and certainly worse with any upper limb weight-bearing activities, handstands and cartwheels and etc. in artistic gymnastics. it was associated with a little bit of intermittent swelling, but certainly no locking or catching symptoms. Her range was reduced. She couldn't get out into full extension or to full flexion. She didn't have any catching or locking. And when her radial on the joint line was palpated, I could certainly feel a small effusion there. And she had tenderness on palpation of the distal humerus on the posterior lateral aspect, which corresponds to the capitellum. When you look at her X-ray in the lateral view, we can get thrown to some extent by changes here in the olecranon, which are actually quite normal. That's just two ossification centres that haven't sort of yet fused, and an otherwise pretty unremarkable lateral. But on the AP view, what we can see here is this little shadow in the capitellum, and certainly on an MRI, that's more significant. Sorry, down here a little bit, I'm up in the growth plate, more significant. And on the T2 images, we can see some bone edema there. Cartilage actually looks all right. It hasn't sort of collapsed or flattened, but we've certainly got a small radiocapitellar joint fusion there. Same image here, just from another angle. And this transverse section really displays very nicely the lesion. So this is osteochondritis dissecans of the capitellum. It's common in gymnasts. It's also common in throwing athletes. So you remember that picture that I showed at the start. I was talking about him loading his medial structures in the sense of valgus force on his medial structures. But what happens on the radius side is you get compression of the capitellum into the radial head, which is probably the mechanism or the etiology in both gymnasts and baseballers. So initially resting from all throwing weight-bearing activities, but unfortunately in this particular case there was no improvement in symptoms, and referral was made to an orthopaedic surgeon, and the child went on to have arthroscopy, micro drilling. Essentially what you're doing there is just drilling into that OCD lesion and just trying to promote bleeding so that you can get some degree of healing whilst you continue another 3-month period of rest. So other forms of intra-articular osteochondrosis are Freiberg's disease or Freiberg's infarction that happens at the metatarsal head. This one's common in dancers, in particular those dancers who have a Morton's foot with a second toe along with the great toe, just puts a great deal of pressure in a very small area. And it's the same etiology probably that we see in Perthes disease, which happens in a younger age group. The last one I wanted to talk about was, this is just OCD of the medial femoral condyle, which is the other common location, as well as the capitellum for osteochondritis dissecans, and this is quite pronounced, and you get the sense that this is actually an area sort of where there's been loosening of that plug. The last, or possibly second to last case I just wanted to go through was a young gymnast who'd had 3 months of right wrist pain, and she was certainly doing a reasonable amount of training, about 16 hours per week, and had pain with upper limb weight-bearing activities. She had reduced range of wrist extension bilaterally, pain on palpation of the dorsal aspect of the distal radius, but no joint effusion. And she's got what's called a distal radial physeal injury. And essentially what's happening there is we're getting compression and torsion of the distal radial physis. And sometimes that causes not only significant pain, but other complications. The main one of which is premature closure of the distal radial physis. So we can see here the physis is closed on this side, about to close on this side. Now, the complication we see is ulnar variance. So you can sort of see this side of the radius is much higher than this side. That causes biomechanical changes in the wrist, and in particular it causes increased stress on what's called the triangular fibrocartilage complex, so known as the TFCC. it's akin to the ACL of the wrist. It's sort of the key ligament of the wrist, and it sort of sits in a triangular band sort of across here where you can see me sort of moving. And so often you'll see these kids where they have a distal radial physeal injury. You'll see them when they're 12 or 13. They'll have some degree of ulnar variance. With rest, you settle them down, and then they come back to you 3 or 4 years later when they're fully mature, but because of their altered mechanics, they have a chronic tear of their TFCC. So that distal radial physeal injury is part of the physeal group of osteochondroses, and the one that you're possibly more familiar with is the slipped capital femoral epiphysis that we see in older children, in particular boys. Very last case, just to highlight sort of one of the other common things that I see is that of the 14-year-old boy who has intermittent lumbar spine pain, a sudden increase in pain following his school athletics carnival, and then the pain settled after about a week. But then he had increased pain when he was playing cricket on the weekend, presented to our emergency department of the kids hospital. He couldn't finish bowling on the weekend, and the sudden increase he had in pain was actually with high jump. And so that's where really sort of understanding the mechanics of the activities that kids are doing is one of the key sort of parts of understanding, I guess, what their risk of injury is and what their pattern of injury might be. His pain was localized to the left side of his back. There was a little bit of radiation of pain to the buttock, but not further. And he had more comfort in sitting and less comfort when he was sort of extending his back. He didn't have a past history of fractures. He had increased his training load in the sense that his deliveries were limited during games, but he used to stay back and bowl and bowl and bowl and bowl. It was around that time that he became symptomatic. To examine, he had a lumbar lordosis with that increased extension, probably putting more stress on the lumbar spine. He had tenderness around L4, L5, and some associated paraspinal tenderness and spasm. He had plain X-rays, and you can sort of see on the plain X-rays here, if you look sort of higher up, this is the pars. Essentially what we're looking for is a stress fracture in the pars or a pars defect. And so we're looking through sort of this region sort of here, and you can see, although we can see the posterior elements relatively well, we've sort of got a lot of sclerosis through there and not that sort of clear determination that we have higher up. Again, you can sort of see sort of in this view sort of here, there's just an absence of pars defect there when you compare it to the other side. These are oblique views, so if you have a history like that and ordering it just an AP and lateral, you might potentially miss it, so you specifically have to ask for an oblique view to pick up a pars intra-articularis defect. With a bilateral pars defect, you can also potentially get a spondylolisthesis, which is where you're getting slippage of one level on the other. It's actually, just trying to see if I can go back to there. It's just a very minor spondylolisthesis there. It's just a very low grade one. Certainly you can get slippage that sort of represents sort of, 20, 25% of the vertebral body above. From an imaging perspective, and a diagnostic perspective, obviously we sort of have to have our clinical suspicions sort of based on the presentation. And then imaging in the past had revolved around X-ray to look for a defect, and then a CT scan if needed, if we weren't convinced that the X-ray was sensitive enough, and a bone scan to look for evidence of metabolic uptake to suggest a stress fracture, rather than that's a lower grade stress fracture or a stress response that hadn't proceeded to stress fracture. And essentially now, sort of these days, we have the great benefit of MRI, which has allowed us to not irradiate young bodies, which is fantastic. And the other advantage too is it's more sensitive. So here we can see, looking at the pars in that sort of same individual, And what we're really looking for is increased T2 signal around the pars. And so we can see that's not present sort of here at L4, but certainly present at L5. And again, we see this big area of increased signals of here, consistent with a pars intra-articular stress response. The treatment is full rest from all activities. The duration really depends on the grade. If you've got just a bone stress response, you might be able to get away with 6 weeks of rest and a 6-week rehab time. But if you've got a pars defect where there's a full fracture line, you're looking at more like 3 months of rest and 3 months of graded rehabilitation. The rehab really sort of revolves around initial rest, core stability to start with during that resting period, and then once you get into the rehabilitation phase, you're starting to upgrade your core stability with more dynamic and sport-specific core stabilization. And the other key thing to remember too is just an analysis of technique. So you certainly see this as an injury in cricket fast bowlers with poor technique, and we also sometimes see it in tennis players, again with that sort of combination of hyperextension rotation of the lumbar spine. Okay, a little sip of water just before I summarise. Hopefully that's taken you through a little bit of what I see in my clinical practice and helped you to understand some of the presenting symptoms and signs that are key to identifying rheumatic disease in the paediatric population. Obviously, investigation should be judicious and referral for assessment if we suspect paediatric rheumatic disease should happen early to make sure we get a diagnosis, but also to reduce the risk of those long-term complications that we discussed. The good thing these days is that there's numerous treatment options, many with a pretty good side effect profile, and the expectation for all children with juvenile arthritis is to be able to return to full activity. And as I say to the kids that I see with arthritis, I hope to get them entirely well so that I'm seeing them for their unique patterns of sporting injuries rather than for management of their arthritis.